Mark your calendars for RSNA 2024, Building Intelligent Connections. Join us in Chicago for the biggest week in radiology from December 1st through the 5th as we explore how to intentionally and intelligently build the right connections between people and technology, expand your network, elevate your skills, and navigate the changes shaping medical imaging. Registration opens July 17th. Go to rsna.org/annual meeting.
Hello and welcome to the RadioGraphics podcast. I'm Dr. Pavan Brahmbhatt, a current radiology resident at Mayo Clinic, Florida, and one of the authors on the paper entitled Amyloid-related Imaging Abnormalities in Alzheimer's Disease Treated with Anti-Amyloid-β Therapy. My wonderful co-authors and mentors are Drs. Amit Agarwal, Vivek Gupta, Amit Desai, Prasanna Vibhute, Girish Patla, all from the Department of Radiology in Mayo Clinic, as well as Dr. Nellie Joseph Mathurin from Washington University in St. Louis. This podcast is also being released in June, which is Alzheimer's and Brain Awareness Month. Our article focuses on the imaging abnormalities that are associated with the recently approved and up-and-coming monoclonal antibody therapies for Alzheimer's disease. These abnormalities are known as Amyloid-related Imaging Abnormalities, or ARIA in short. We then proceed to briefly outline the updates in the neuropathology and imaging of Alzheimer's disease. Lastly, we dive into and discuss the rationale of use of these anti-amyloid monoclonal antibodies, or MABs for short. Some common ones are the FDA-approved aducanumab, the FDA-approved lecanemab, as well as emerging therapies that are currently in trials, such as donanemab. In order to set the stage, we're first going to discuss the neuropathology of Alzheimer's disease. The two primary lesions associated with Alzheimer's disease are senile plaques and neurofibrillary tangles. Senile plaques are defined as extracellular non-vascular aggregates of beta amyloid, while neurofibrillary tangles are the second hallmark, and they're defined as intraneuronal protein inclusions. These protein inclusions result from misfolded and abnormally phosphorylated tau protein aggregates. These aggregates are commonly found in the entorhinal cortex as well as the hippocampal system. One of the more prevailing hypotheses regarding the pathology of Alzheimer's disease is known as the cascade hypothesis. This hypothesis postulates that the accumulation of beta amyloid in the brain is actually the critical initial step, and this results from an imbalance between both production as well as clearance of beta amyloid. This accumulation drives Alzheimer's disease and really sets the stage for further aggregation. Moreover, we commonly see the diffuse plaques as well as the benign plaques occur earlier than the neuritic plaques, which supports the theory that early intervention with a focus on decreasing production or increasing clearance of this beta amyloid may help in the long-term progression of the disease. The creation of the Alzheimer's Disease Research Framework in 2018 resulted in the recognition of numerous imaging and CSF biomarkers. Specifically, 3 categories were created, named as amyloid, tau, and neuronal injury. Each category is defined by 1 CSF biomarker and 1 imaging finding. PET is increasingly becoming recognized as a vital tool for the earlier diagnosis of neurodegenerative conditions. The advent of radiotracers specifically targeting Alzheimer's proteins such as beta amyloid and tau offers more specific information than conventional imaging such as MRI and FDG PET. Amyloid CT or MRI PET is now being widely used for Alzheimer's disease with multiple FDA-approved tracers such as florbetapir and flutemetamol. The sensitivity of amyloid PET has been reported to be between 60 to 100%. Additionally, tau tracers, flortaucipir being the only FDA-approved one, has a strong ability to discriminate Alzheimer's from other neurodegenerative disorders, with a sensitivity and specificity of 90 to 95% respectively. Unfortunately, tau tracer imaging has been limited to a few major medical centers right now. Current treatment modalities in Alzheimer's disease have largely been focused on symptomatic control with cholinesterase inhibitors like donepezil. As discussed earlier, amyloid plaque deposition is really the main inciting pathogenic event in Alzheimer's disease, setting the stage for the downstream pathogenesis. Most recent trials have focused on stopping amyloid plaque formation or facilitating its removal. This is achieved by unbundling the amyloid bundles through microglial or complement activation. In June 2021, after almost 20 years, the FDA approved a new Alzheimer's medication, aducanumab. Aducanumab is an anti-amyloid monoclonal antibody. Lecanemab was subsequently given accelerated approval by the FDA in 2023. This brings us to amyloid-related imaging abnormalities, or ARIA. Once therapy is initiated with these anti-amyloid mAbs, vessels that have pre-existing amyloid deposition become more susceptible to extravasation events. This can split into two directions, ARIA-E for edema or effusion and ARIA-H for hemorrhage. If the extravasation event is the leakage of proteinaceous fluid, that results in ARIA-E. If the extravasation event is the leakage of blood products, it results in ARIA-H. The degree of this increased vascular permeability depends on the severity of the pre-existing amyloid deposition, the efficiency of the amyloid clearance, as well as the local inflammatory response. Long-term therapy with these mAbs typically results in clearance of the amyloid deposition in the vessel wall, with subsequent reorganization of the arterial smooth muscle, which restores vascular integrity. 3 critical risk factors have been identified for the development of ARIA and are as follows. The first being drug dosage, the second being apolipoprotein E allele carriership, and the last being the presence of pretreatment hemorrhages such as microhemorrhage and siderosis. The only modifiable risk factor here is the drug dosage. It's standard practice to start at a lower dose of 1 mg per kilogram for the first 2 infusions, then moving up to 3 mg per kilogram for the third and fourth, 6 mg per kilogram for the fifth and sixth, and finally to the optimum target dosage of 10 mg per kilogram from beyond the 7th infusion. This titration is usually done over a period of 20 to 24 weeks. Most cases of ARIA tend to develop during this dose titration or after achieving the target dose. So why should radiologists care about ARIA? So the only way to actually diagnose ARIA is through MRI. Subsequently, the International Collaboration for Real-World Evidence in Alzheimer's Disease, otherwise known as ICARE-AD, established guidelines for baseline imaging as well as serial monitoring of this side effect. This single-arm multicenter body evaluated the safety and the efficacy of these anti-amyloid mAbs across more than 200 centers in the United States. The recommended imaging protocol includes a baseline or pre-treatment imaging examination as well as a post-treatment imaging examination before the 7th and the 12th infusion. They then recommend imaging every 6 to 12 months after that for up to 5 years. They go even further to recommend the mandatory sequences, which include 3-dimensional T2-weighted fluid-attenuated inversion recovery, or FLAIR, T2 star-weighted gradient recalled echo, as well as diffusion-weighted imaging. The FLAIR sequence really forms the mainstay for diagnosing edema and infusion, or ARIA-E, and GRE sequences are used to monitor hemorrhagic contents, or ARIA-H. A section thickness of 5 mm or less is recommended for all sequence types. In order to ensure adequate and appropriate monitoring, apart from the standardization of the protocol above, another essential factor is actually the standardization of the magnet strength. While high-field strength MRI scanners may have greater sensitivity, the use of a 1.5 Tesla scanner is endorsed as a minimum standard. This is due to the availability of higher field scanners being limited to specific centers. If a center has easy availability to high field scanners such as 3 Tesla or 7 Tesla, it is imperative to maintain consistency not only with the field strength but also the vendor type. A team-based effort with collaboration between the clinical neurologist, the schedulers, as well as the neuroradiologist is the best way to ensure adequate monitoring. Ideally, every center should identify a few trained neuroradiologists to lead this effort with close communication between the team. Even one wrong imaging examination can derail the monitoring process. Although ARIA can occur anytime during therapy, clinical suspicion should be highest early on in treatment. We would now like to further elaborate on ARIA-E. Again, ARIA-E is characterized by parenchymal edema and/or sulcal effusions, and this remains the most common side effect of the anti-amyloid mAb therapy. The presenting symptom of ARIA-E is usually headaches. Chronologically, ARIA-E occurred most frequently between 3 to 6 months of treatment, and its incidence sharply dropped after the first 9 months. Parenchymal edema is easily detected on T2 weighted FLAIR sequences, and it appears as cortical, subcortical areas of hyperintensity with mild gyral swelling and mass effect. Exudates within the sulci are also seen as FLAIR hyperintense signal and lack of CSF signal suppression, which may present with or without enhancement. We stated earlier that ARIA-E stands for edema or effusion, however, they commonly coincide. In regards to location, these are most commonly seen in the occipital lobes, followed by the frontoparietal lobes, and they are least common in the cerebellum. When edema and effusion do coincide, they are commonly seen in the same region rather than distant from each other. The grading of ARIA-E is dependent upon the size of involvement and guides decision on drug continuation or cessation. A single location of less than 5 centimeters maximum dimension is graded as mild, whereas involvement of more than 10 centimeters is graded as severe. Most ARIA-E events are asymptomatic and do resolve with dose adjustment. Moving on to ARIA-H. ARIA-H is characterized by parenchymal microhemorrhages and/or superficial siderosis. The incidence for this is roughly around 15 to 20% in most clinical trials. Microhemorrhages tend to be more common than siderosis, and they are defined as punctate rounded foci of signal dropout on the gradient sequences, which tend to measure less than 1 centimeter. Superficial siderosis commonly manifests as curvilinear areas of signal dropout along the brain surface and is the least common manifestation of ARIA. When superficial siderosis is present, however, it does frequently require cessation of therapy. Grading of ARIA-H severity is dependent upon the number of microhemorrhages, and it is because of this that careful assessment of the baseline number at the pre-treatment or baseline MRI is critical. These microhemorrhages are best seen with gradient or susceptibility weighted sequences. The presence of 4 or fewer microhemorrhages or less than 2 focal areas of superficial siderosis grades ARIA-H as mild, whereas 10 or more microhemorrhages or more than 2 areas of superficial siderosis qualifies it as severe. Since grading of ARIA-H is dependent upon the counting of individual microhemorrhages, a standardized imaging protocol with consistency in both the sequence as well as the scanner is necessary to facilitate this. Even though T2 star weighted GRE sequences are the recommendations per the clinical trials, susceptibility weighted imaging, which offers higher spatial resolution, is now standard at most centers across all vendors. As stated earlier, the basis behind both ARIA-E and H is vascular permeability secondary to anti-amyloid MAB treatment. Therefore, it is common for both these entities to occur together, as both fluid and heme products may cross the damaged vessel wall. It's postulated that some amount of fluid usually extravasates with blood, and therefore some amount of ARIA-E may always occur with ARIA-H. However, the opposite is not true, and there is frequently no definite hemorrhagic leakage with proteinaceous fluid. Continuation of therapy in those with ARIA relies heavily on the radiologist appropriately grading and monitoring these imaging findings. In most cases, therapy may continue in asymptomatic patients. ARIA-E tends to be more transient, and therapy may continue or be temporarily stopped. Stoppage of therapy in ARIA-H depends upon the severity and whether or not it is stable. Moving forward to the radiographic differentials and the common interpretation pitfalls. Inflammatory cerebral amyloid angiopathy is an umbrella term which encompasses 2 subtypes, CAA-related inflammation and amyloid-beta-related angiitis. There is significant overlap between the pathophysiology of ARIA and CAA-related inflammation. CAA-related inflammation is considered a spontaneous human form of ARIA, and it is an autoimmune encephalopathy secondary to autoantibodies targeting the beta-amyloid protein which is deposited in the vessel walls. These are commonly the cortical and leptomeningeal brain vessels. Imaging findings in inflammatory CAA are indistinguishable from those of ARIA, and the only difference is the clinical history of MAB administration. Patients with significant background disease of CAA are commonly excluded from these trials. Therefore, any new area of vasogenic edema in patients who are receiving MAB therapy is classified and treated as ARIA. Apart from amyloid angiopathy, other conditions in the imaging differential diagnosis for ARIA-E include posterior reversible encephalopathy syndrome, otherwise known as PRESS, progressive multifocal encephalopathy, subacute infarcts, and vasculitis. Among these conditions, ARIA-E has a very striking resemblance to PRESS, with both having a predilection for the occipital lobes with petechial hemorrhages and both being reversible. In summary, anti-amyloid MAP therapy is an exciting new frontier. Prior to its advent, therapy for Alzheimer's disease was primarily symptomatic. Now, we are able to target what is thought to be one of the main pathogenic factors in its progression. The most common side effects of MAP therapy includes ARIA-E and ARIA-H, and imaging forms a crux for both detection and grading of these changes. We highly recommend the audience to review the article, which contains excellent imaging case examples as well as tables in order to guide therapy. We thank you for your time and hope that you found this discussion on amyloid-related imaging abnormalities in Alzheimer's disease treated with anti-amyloid-β therapy useful. Thank you for joining this RSNA RadioGraphics podcast.